Good afternoon and a very warm welcome on behalf of Sonova and Sonova's Audiological Care Network to our second virtual physician symposium, this time on tinnitus, research, applicability and best practice. At Sonova, our global audiological care network is your local partner in hearing care with clinics all across the globe. We strive for improved quality of life and well-being through optimal hearing care. In our first virtual event in March this year, we delved into the correlation between hearing loss and cognition. And with that, we launched a series of virtual symposiums with the goal to present to you the latest research and best practices related to actual topics connected to optimal hearing care. During these events, you will have the opportunity to ask questions to our panel of international experts in the various fields we are presenting on. Whether you already joined our first event in March or whether this is your first time participating in these symposiums, we hope that you will continue to join us and that these events add value to you and your patients. Today, we will be talking about tinnitus, which can have a very strong impact on the quality of life of a person. In the past, the message to tinnitus sufferers often was pretty hopeless. Get used to it, it can't be cured anyway, to put it pretty drastically. Today, we want to discuss why we think this message is wrong. Despite tinnitus not being really curable, a lot can be done to provide significant relief to tinnitus sufferers. So today we bring together experts from around the world to crowdsource intelligence on this challenging topic. The program will start with research underpinnings. It will unfold to explain different treatment modalities and options, and it will end with practical clinical guidances from an ENT currently working with a sizable tinnitus caseload. The entire program will take 90 minutes. We have a few housekeeping items before we can begin with the program. During the three presentations, we invite you to submit questions via the chat function. We will answer and discuss these questions during the panel discussion with our experts in the last part of our symposium today. With our event today, you can collect 1.5 hours of education credits to go towards licensure requirements. Therefore, we've provided this presenter disclosure and learning objectives for today. To collect your education credits, you will need to complete a quiz, which you will receive after the event. The required score is 70% and it can be tried twice. We will also ask for your feedback on the symposium today, and we will give you a sneak preview on our future solution on tinnitus management. With that, it's time to start the program. Let's introduce our first speaker, Dr. David Baguley, who is Professor of Hearing Sciences at the University of Nottingham and who is the Deputy Lead of the Hearing Theme within the Nottingham Biomedical Research Centre. David has published over 200 scientific papers. He has edited and co-authored 5 books and written many book chapters. The main theme of his research includes ototoxicity, hyperacusis, and tinnitus. And on this topic, David is going to talk to us about. So thank you, David, for joining us. It's a great pleasure to have you here. The screen is all yours. I look forward to your presentation.
Hello, and thank you so much for the invitation to give this talk. It's really exciting that so many people are interested in tinnitus now. That's a great encouragement both to clinicians and I'm sure to the patient community. My name is David Baguley and I work in Nottingham at the university there. And we have a translational hearing sciences group, taking ideas from the basic scientists and pulling them into the clinic, but also taking ideas from the clinic and setting the agenda of the basic scientists. So a full spectrum research group with a translational part. What I'd like to do in the time we have together is to look at 4 aspects of tinnitus where my understanding is there's been some recent progress and some new insights. For us to look at something that's now called tinnitus disorder, for us to look at the patient question, what causes it? The patient question, what will happen to me over time? And then finally, the really important question from the patient, why is there no cure? Perhaps why is there no cure yet might be the better way of putting it. So let's walk through this structure and see where that takes us in terms of new perspectives and insights. And the first thing to note is there's been some work from a group of people, and I was part of this group, and it's about 50 authors that contributed to this across the whole spectrum of the tinnitus community, looking at the distinction between tinnitus, that being a sensory component, and tinnitus disorder, including both the sensory component and the associated suffering. Insomnia, anxiety, depression, poor concentration, that constellation of symptoms that are associated with the sensory component that we're also aware of. So a proposal rather than a consensus document, because there was difficulty reaching consensus. It's fair to say the tinnitus community has many different perspectives. It's multidisciplinary, and that is very powerful and very positive. However, it doesn't always lead to unity. But this is a proposal that says, consider these 2 aspects separately. And in a few moments, we're going to linger with the idea of the sensory component of tinnitus and look at some of the insights that have been gleaned on mechanisms. But another aspect of this tinnitus disorder is the nature of it being troublesome and bothersome. And here's some new information that was taken from the Tinnitus Hub web-based discussion forum, and the study was performed by colleagues largely in Nottingham, though I wasn't part of this particular group. And they analysed the Tinnitus Hub forum and looked for themes within that to try and gain insight into the lived experience of patients. And what was new was the concept not of the tinnitus loudness or of the percept itself, but of its intrusiveness, its ability to drive forward into awareness. And this is a new insight, and people are developing now instruments to try and measure intrusiveness, because this might be one reason why some of our treatments don't seem to be truly effective. We may be measuring the wrong things. But alongside the intrusiveness, colleagues found more familiar concepts of the sense of control patients had, or the forum contributors, their acceptance of the tinnitus, their ability to concentrate, and their ability to ignore the tinnitus. So some positive, some negative there, but some new information. But let's stick with the sensory component of the tinnitus, as colleagues later in the meeting are going to be talking about the more associated and psychological aspects. In general, there are 5 themes presently of inquiry from the auditory neuroscience community regarding tinnitus mechanisms. I think it's important when you have a patient with troublesome tinnitus that there is a conversation about mechanisms, as they are often intensely curious as to what actually it is. Colleagues are looking at increased spontaneous activity, but also increased synchrony in activity. And that appears to perhaps be more important, the idea that the auditory system can fall into a rhythm in itself and to move that forward. Concepts of increase in neural gain, that ability of the auditory brain to set its operating point depending upon the level of input and the level of salience of the sound that it's paying attention to, whether that be internal sound, tinnitus, or external sound. Colleagues are looking at disseminated network activity, both within the formal auditory neural system, but also more widely, and we'll come to look at that in just a second. And then a new model, which has been called the precision model, which thinks about how the tinnitus can be driven forward into the auditory brain. These clearly are not mutually exclusive perspectives, but they are important to consider. Let's firstly have a look at the concept of neural gain. And the important work here is being done by Dr. William Sedley, who is an academic neurologist working at Newcastle University Hospitals and academic group in terms of his tinnitus program. He's been thinking very carefully about the role of auditory gain in tinnitus and the often associated hyperacusis. And in particular, a new insight there is in this issue of anticipation. This gentleman is waiting for an important phone call. Might be his bank manager, might be his estate agent, might be his family doctor, might be the announcement of a success at a job interview. But he's waiting for the telephone to ring. And when it does ring, he will startle and it will seem loud, despite the fact that this is the very sound that he's anticipating, expecting, and recognizes the sound. So his anticipation has potentiated his auditory gain. And that's potentially extremely helpful in terms of understanding tinnitus, this idea that the expectation that it will be there, potentiating the intrusiveness, that concept again, and that's potentially really rather important when we come to try and look at therapies that downrate the intrusiveness or salience of the tinnitus percept. Now, another question that patients will very often ask, and this work again from Will Sedley, is has anybody ever measured tinnitus? And the answer, until really quite recently, was that the only measures that we had were indirect. Functional neuroimaging is of course useful and important, but it's essentially an indirect measure. Here's a patient that was seen in Iowa, and it's a case report, but it's rather important. Patient was male and 50 and had bilateral tonal tinnitus. He also had intractable epilepsy, and the neurosurgical group were going to perform a craniotomy to monitor the activity of his left hemisphere to try and identify the focal points of the epilepsy and to intervene with them. What was also notable about his case is that his tinnitus was extremely amenable to residual inhibition, that phenomenon whereby the playing of an external sound at an intensity where it can blend or mask the tinnitus reduces the tinnitus for some time after the external sound has ceased. This was particularly evident in this gentleman's case, and this enabled, during the intracranial monitoring, measurements to be taken with tinnitus and then without. And that's the important thing, because then you can, by subtraction, get a direct measure of the tinnitus. Now, the neuroscience is complex. In my head, I try and understand this by thinking of an oceanographer on the surface of the ocean, measuring what's below her in terms of movement, activity, temperature, depth, network, groupings of shoals of fish. So an oceanographer is able to determine what's happening deep down within the ocean. Similarly, with this monitoring, colleagues were able to measure what's happening deep down within the auditory brain concerning tinnitus. Essentially, they found three networks. A network that was driving the tinnitus, again, important in terms of the growing precision through the auditory system, but also important in terms of the intrusiveness, again. A memory network that seems to hold the tinnitus, and the tinnitus percept itself, the sensory component, to use that term again. This again is important. Tinnitus driving, a patient will say to you, I'm watching my favourite television programme or listening to my favourite piece of music, and the tinnitus is so intrusive, I can't pay attention to these external sounds. Some patients will say, when I wake in the morning, there's no tinnitus, and then my brain remembers it. So the tinnitus memory network, and then again, the tinnitus percept itself. So some new information and new perspectives there in terms of what actually constitutes the tinnitus, the sensory component. The second question this hypothetical patient is setting to us at this meeting is, will my tinnitus improve? So this is a patient in the consulting room with us saying, what does the future hold for me? And until recently, there wasn't firm, large-scale information in that regard. But we've used the biobank in a collaboration between Nottingham, Manchester, the British Tinnitus Association, and now groups in Australia, looking at the biobank. Let's explain what the biobank actually is. It's a UK-based data set that's trying to look at a wide range of serious, life-threatening and life-altering illnesses. It's recruited 500,000 people in the middle years of life, and a large number of assessments were taken, both questionnaire instruments and in person. The data set is rather whiter than the general UK population, and it's rather more middle class and educated than the general UK population, but it's reasonably representative. And marvellously, there are repeat measures on a growing number of subjects within the biobank, of whom at the present time about 20,000 have had repeat scanning and tests. There's quite a lot about hearing in the biobank. There's no audiometry, and that's unfortunate, though at the time that the biobank was set up, online audiometry was rather more difficult than it's proven to be during the pandemic. But there was a digit triplet test, and left and right ears were tested separately. So this is a proxy for audiometry, but reasonably good self-report questions. There are some problems with some of them, but actually a reasonably good set of questions. The tinnitus question is the same question essentially that was used in the National Study of Hearing, again a Nottingham, UK project. Tinnitus more than 5 minutes at a time, and a measure of severity. How much do they worry, annoy you, or upset you when they're at their worst? So we had a look at the biobank data and found that just under 18% of the cohort reported tinnitus, and in just under 6%, this tinnitus was bothersome. The associations were reasonably as one would predict, being older, being male, poorer speech, more noise, more music noise, ototoxic medication, and neuroticism, which has been indicated in previous biobank studies. What were the associations with tinnitus that was bothersome? Well, conversely, being female, being poorer, poor hearing, work noise, again, ototoxic medication, and the personality attribute of neuroticism. So reasonably good prevalence data there, and really good, nice, big numbers. This is a very big and useful data set. There were just under 4,000 people who'd had the repeat measure, the longitudinal analysis. The point of remeasurement was between 2 years and 7 years. That's regrettable that there was that variation, but that's the reality of looking at these big data sets. In the people who had no tinnitus at measure 1, but yes tinnitus at follow-up, there was a 4-year incidence of just under 9%. So if you're walking around without tinnitus, in the next 4 years, your risk of developing tinnitus is just under 9%. What about the people who had tinnitus at the baseline measure, but no tinnitus at their follow-up? 18.3%. But there's a problem with this data, because 63 of these people at measure 2 said they'd never ever had tinnitus. So it does seem that there's some problems with autobiographical memory in terms of tinnitus research, and that's something that's, I think, really going to have to be borne in mind when we look at some of the other big data sets around the world. You were less likely to have your tinnitus resolve over the follow-up period if you had hearing difficulties. What about the people who had tinnitus at both measures? Well, just over 1,000 of those, and the vast majority of them don't change at all, don't shift at all. In just under 10%, the tinnitus improved. In just under 10%, the tinnitus worsened. So a broadly equal chance of going in either direction. I think my thought is this is an indicator to say to people, if you do have tinnitus, do something about it, as it's actually rather unlikely to change spontaneously. And it looks as though we may have overemphasized in the tinnitus world the possibilities of habituation over time. And then the final question that's on our patients' lips: why is there no cure for tinnitus? Well, this is a paper that has had over 200,000 reads on the internet and was designed formally to try and instigate debate and to try and be a wake-up call for the reasons why we haven't yet managed to find the elusive cure for tinnitus. Involved ENT, charity, drug companies, and clinical academics as well. What were our findings? Well, the first reason why there's no cure for tinnitus is there simply hasn't been enough work done on it. This is a rather salutary graph. You can see there's a line for number of publications per year for depression. Very heartening that that's now over 20,000. Anxiety, again, heartening numbers. Deafness, there's been an uptick, you can see, in the third line on the graph. Tinnitus, some change, but not sufficient. So one of the reasons we haven't yet found a cure is that there's been insufficient research. But there are other problems. No clear definition of the problem. Well, we're starting to work on the language, and we've talked about that this afternoon. The epidemiology has been unclear, but now that we're using some of these large data sets, it may well be that we can get deeper into that, and particularly the questions of change over time. The actual mechanisms of tinnitus have been unclear, but there's work really powering on in that area, and we've looked at that at this meeting. Multiple different subtypes and this heterogeneity of tinnitus has been a problem, and no objective measure or biomarker. And again, people are working on that. We haven't had time this afternoon to do that. So in conclusion, I'd like to summarise by what I've said is that tinnitus remains a highly complex and variable problem, and progress here has been frustrating and elusive. But I do think there are grounds for cautious optimism at the present time. Thank you very much for your kind attention.
Thank you, David, for your very interesting and very insightful presentations. So if you have any questions for David Baguley, please submit them in the chat function and we will address them in the Q&A session later. I would like now to welcome Dr. Rilana Cima, who is currently visiting professor at the University of Leuven in Belgium and at the Adelante Center of Expertise in Rehabilitation and Audiology, as well as at the Maastricht University in the Netherlands. Since she started as a clinical psychologist in 2004, she has been developing a CBT-based treatment protocol for tinnitus management, which later became the standard treatment for all tinnitus patients in the Netherlands. Today, Rilana is going to give us insights around the psychological perspectives in chronic tinnitus disabilities. Thank you, Rilana, for being with us today. We are very much looking forward to hearing your presentation. The screen is all yours. Thank you.
Today, I want to talk to you about some psychological perspectives when we meet patients suffering from tinnitus. I will talk about what it is within the psychological framework. I will explain a little bit about how we came to this idea. Then I'll explain the model we use in making our predictions and research, as well as basing our treatments on. I will tell you a little bit about the treatment. I will present some evidence for the effectiveness of the treatment, as well as some of the mechanisms in the model. and I hope to provide you with the current state of the art. The mystery. As we all know, tinnitus is the perception of sound without the possibility of the patient or us to point to a source which produces the sound, so that we cannot point to a physical source. We also know it's very common. 1 in 5 of the adult Western population is able to, at least in one point in their life, to experience a continuous tinnitus. However, it's a very small subgroup who starts to suffer from the perception on a daily basis. It's mysterious in that tinnitus perception usually is not harmful at all. However, in a very small subgroup, it can produce a severe disability, though. These two things, tinnitus perception and tinnitus disability, are not the same things. The audiometric or sort of perceptual characteristics of the tinnitus are not very good at predicting tinnitus suffering. So the quality of the sound, loudness or pitch, hardly predicts the levels of suffering of the patient. In our clinic, 60% of our patients has so-called normal hearing as measured on an audiogram. We also know that of the hearing disabled population, 70% has or is able to perceive a tinnitus, though less than half of them actually suffers from it or is really impaired by it. Tinnitus aurium is, of course, the Latin term for the jingling of the ears, and it can be anything really. It can be a singular sound, it can be a combinational sound, it can be heard in one ear, in both ears, in the head. The interesting thing is that it's not measurable or quantifiable by physical recording, so we cannot observe the sound, so to say. Also interesting is that it's as of yet not traceable to a singular disease, injury, or pathology, which oftentimes means in these health-related complaints that when there is no disease, there's actually also not really a cure for it. As we have said, the perceptual characteristics of the tinnitus are not the same or do not predict the tinnitus severity. Therefore, to perceive a tinnitus is not to say that you will also develop tinnitus disability. Even so, if you have tinnitus disability, or if you indeed are impaired by the perception, you do feel ill, at least, and you do report severe suffering, and we can speak of, indeed, harmfulness of the tinnitus in those cases. But where is the harm, we ask ourselves? Maybe tinnitus disability, not the perception or the occurrence of tinnitus, but the disability as a result of it, can be best explained in psychological terms. And let me take you to the theorizing I did myself as well. So if you look at the most common definition, tinnitus being the continuous perception of sound without identifiable external acoustic source, this actually is a very good description or definition of tinnitus perception. However, we cannot use this very well in the clinic because people are not coming to us because of they perceiving the tinnitus, but they come because they are disabled by it. So what if we were to define the chronic disabling tinnitus as not just a negative auditory, but also emotional experience associated with or described in terms of actual or potential, and in this case, usually psychological harm. So in this case, we have terms here which allow us to communicate to patients that indeed there is suffering ongoing, that impairment can be seen, and that is harmful for the quality of life of the patient on a daily basis. So what do we know? As we have said, there is no singular cure available for tinnitus. So in that way, we have to always disappoint our patients. It's also a known fact that standardized practice or standardized protocol for encountering the patient is also very scarce. Most offered treatments at this time are the ones who use some sort of sound therapy. The most well-known might be the TRT therapy, and usually, even if it's not the pure TRT, it is an extensive counseling with the patient, as well as the use, or at least advising to use sound enrichment or the use of sound devices. However, the effectiveness of these types of therapies have not been robustly established yet. We do have some evidence on the effectiveness to decrease disability due to tinnitus by implementing a CBT-based approach, cognitive behavioral treatment. And we see that if you look at all the studies, that the evidence keeps growing, and we can conclude that evidence is beginning to look quite robust. But why? Why is it the case that the cognitive behavioral framework offers this solution? So what if we look at tinnitus as within the framework of pain perception? If you look at pain, we see that the severity of the injury is not predictive of pain perception. People can have large wounds of large harm with very small perception of pain, and a very small wound can cause extreme pain perception. Harmless stimuli, therefore, can also provoke intense pain, and severe injury can coincide with no pain perception at all. Location of the injury also doesn't predict very well where people actually feel the pain, and therefore, if we look at chronic pain, we see similarly that there is no physical basis to be able to medically explain why, how, and on what intensity the pain is felt in the patient. We can already see that the similarity with chronic tinnitus, or the perception of tinnitus as opposed to the disability due to tinnitus, is quite firm here. If I were to replace injury and pain with the words hearing loss and tinnitus, we have a one-to-one translation. So if chronic pain is a painful phantom perception, since we do not have a physical source, then tinnitus might be seen as an auditory phantom perception, where we also are not able to find an appropriate stimulus to explain where, why, or how loud or in what form the tinnitus is perceived. So how do you counter these mechanisms happening in your brain and body? So what we usually do in psychological treatment or cognitive behavioral treatment traditions is that in situations where a person is highly fearful of a particular thing, which we often call phobic, we will use exposure. So what is exposure? Actually, exposure means that instead of the patient's natural behavior, natural involuntary safety-seeking behavior, you will go through methods with the patient to stop avoiding and start encountering the situations they are the most fearful of. Because mostly safety-seeking happens because of threat expectancies. The person feels that something very bad might happen, which rationally we know this is not happening. So you will not, usually a tinnitus patient thinks the tinnitus will get louder and louder and louder. The person thinks that he will go insane, get a mental breakdown, faint. All these things never happen. At least they have never happened to one of the patients in my clinical experience. Of course, patients faint sometimes, but not usually as a result of tinnitus. So what we are going to do is to look for these threat expectancies and ask patients, what do you think will happen? Do an exposure to the tinnitus or a silent room or a nasty sound or something they feel fearful of, and then ask whether their expectations happened. So what happens if they consciously go through this process of exposing themselves and noticing the worst case scenario actually did not happen? They reassess the threat, and if you reassess threat, your interpretation will also follow, and the mechanisms in the fear avoidance model will also change. So functional expectations of the situation will ensue. So people will think, oh, okay, if I just do these daily activities without trying to avoid or escape, nothing bad is going to happen, and I can go about living my life. Fear will decrease because the high threat expectations will dissipate, and eventually the person is able to usually see the tinnitus as something which is present in their perceptual environment, but is as such in itself not malignant. So safety behaviors are not needed. This is not always a very conscious process. Sometimes unconsciously these things happen first. And if that is the case, if the tinnitus is no longer a reason to feel threatened or adjust your daily life activities around, we can say there's recovery because there's no more disability. Do we have evidence? Yes, indeed, we do. We have, at this time, performed 2 quite large trials in which we have seen that this exposure treatments does lead to significant benefits in quality of life. If you look at the orange line here, we see that over time, people going through the treatment experience increased quality of life. They experience decreased, again, the orange line, in tinnitus handicap, as well as a significant decrease in tinnitus severity. The blue lines here are the control condition, which was also an active treatment. And this treatment was the sound education and counseling condition. So without the exposure element. And we see that if you modulate the exposure element, you see that this actually provides the patients with hopeful benefits. So what we also have seen in other cross-sectional studies, that if you are able to decrease fear of tinnitus, that tinnitus disability one-on-one decreases. If you look at treatment effects, we have seen that the effects, we have seen the beneficial effects of the exposure treatment are largely explained by decreases in fear. So if you look at, okay, you say the treatment works because there's less disability, then the next question would be, but why? How come? And then you do a mediation analysis, and you see that if you look at fear, and you put that in the model as well, that this takes over the explained variance in the model. And last but not least, we have seen that if you are able to manipulate neutral tones in a healthy population, in threat value, that high threatening tones decrease task performance, whereas the same tones without the threat value does not have an influence on task performance of healthy participants. The mediation analysis I just explained is seen not only in quality of life. If we try to explain why the treatment was effective as measured on tinnitus severity, or as measured on tinnitus impairment in daily life, we see that on all three of these outcomes, fear plays a major role. Fear, the decrease in fear of tinnitus, so the decrease in the threat value of tinnitus indeed, explains why we can measure benefits on quality of life, tinnitus severity, and tinnitus impairment. So we can explain the treatment effect of exposure because there are reductions in tinnitus fear, which exposure is aimed at. We did a validation study in a separate subgroup of also 430 patients, which was, we wanted to check this, whether if we would implement this treatment and having the treatment performed by a different team in a different sample of patients on a different location, whether we would have the same effects. This is sort of a validation of the treatment, whether it works in another clinical setting as well, and whether or not our first results was a fluke. And we see that in all our outcome measures, we see similar beneficial effects in the separate group of patients. Better yet, we see a little bit stronger effects in the second study. The second study, the paper is currently under revision, so we hope to be able to publish these results very soon as well. And we see the same benefits on the same outcome measures. Quality of life significantly increases, tinnitus severity and impairment lessen, of course, and we see positive effects on general mood, depression and anxiety, tinnitus catastrophizing, and tinnitus-related fear. Some key points to remember here is that we have to communicate to patients that tinnitus indeed is very annoying and disabling, but in itself it's not harmful and therefore not needed to be avoided. So same goes for fear. Fear is of course not very nice to have, but it's not harmful to feel. So no need to avoid fear or threat in this case. So the model predicted that the more patients expose themselves to their most feared situations, the tinnitus perception usually, the more they are able to learn or relearn that the thing they think is going to happen actually doesn't happen that much or in that, for that amount, so in that severe level that they think. If they are able to consciously be aware of that fact, they learn that there is no need for seeking safety, nor of reorganizing or adjusting their life, nor their valued life goals. They will start exposing themselves and living their daily life as wished. As a result, we hope to see tinnitus disability recovery. We do have some challenges, of course. Not everyone in our trials benefited equally, and some of the patients even did not benefit at all. There were luckily no adverse effects, but an exposure treatment is quite intensive, and you'd hope that if people invest in going through the treatment, that they would have benefit. What I want to do for today is to give you some take-home messages to use in your clinic or with colleagues or with patients if you have the psychological perspective in mind. So if you have a patient who is suffering severely and is going through a particularly hard time at the moment, these are some of the things you might say to them instead of it will never go away. There's nothing that can be done, and this is the way it's going to be. So that we will not say, because this will increase threat and fear. And what we do say is that, of course, you can be very anxious because of the tinnitus, but it will not threaten your life nor your physical health. Usually the tinnitus improves, whether on the day itself or whether over time. What we also know, the tinnitus itself, the perception doesn't really change or worsen over time. Tinnitus does not cause hearing loss. It is, of course, the case that hearing loss is associated with tinnitus, but it will not always, it does not always mean that the person will develop a tinnitus perception, and not at all that they will have a tinnitus disability. We know that being worried or having a negative interpretation of the tinnitus, or a negative idea about recovery possibilities or treatment possibilities, will worsen the situation. So it's more predictive of more disabling tinnitus than damage to ear systems or hearing losses. We have seen that. Brain scans do not really help to determine your current episode of tinnitus or the likelihood, how it's going to go in the future. Tinnitus flare-ups, so the temporary perception of more severe tinnitus, which patients often mention, are more likely caused by changes in your activity or stress levels or mood, and not per se to more damage structurally in ear, head, or mentally. Exposure to all kinds of sounds, including silence, including your own tinnitus, is safe and healthy. It's not bad to do that. Normal sound exposure is not really linked to increased tinnitus disability nor tinnitus episodes. And it's also important to tell patients that effective treatment is available. It is safe, and it does not have to cost a lot. So with this take-home message, I would like to end this presentation. There's an interesting quote in the U2 song, which often people are not aware of. And that's it. Thank you very much for your attention and your willingness to listen to the psychological framework, which might explain tinnitus disability. And yeah, good luck.
Thank you, Rilana, for your exciting presentations. If you have any questions to Rilana, you can also submit them in the chat function, and we will cover the questions later on in the Q&A session. I would now like to welcome Dr. Albert Mudry, who is adjunct professor at the University of Stanford in the United States. Albert is a trained physician with a specialization in otology. He trained in Switzerland mostly, but also had stages in Germany. And Albert is going to talk today about the best clinical practice around the first clinical screening of a tinnitus patient. Albert Mudry also has published a series of books and around 180 papers on various topics. Without further ado, let me welcome Albert Mudry on screen. It's a pleasure to have you with us today, and we look forward to your presentation. Thank you.
Dear colleagues, I will present you today the first clinical screening of a tinnitus patients that we conduct in the private ear clinic in Lausanne, Switzerland. We are 3 specialists concerned with this consultation. Florence Mudry-Secrétan, a pharmacist, who is his tinnitus consultant in the clinic, Olivier Gache, an audioprosthetist, and myself, an otologist. Unfortunately, in Switzerland, we do not have audiologists. I have no conflict of interest and no financial support. I am a medical advisor of Aurelim, a society developing with Sonova a new app for tinnitus patients. I am also affiliated with the otolaryngology department at Stanford University, responsible for research in history of otolaryngology. Up to 68.5% of the population perceive tinnitus as a temporary condition at least once. We can add that one patient is one tinnitus. All the main medical societies, Association for Tinnitus, as in Europe and in US, published their own guidelines, notably about the diagnostics, the assessment, and the possible therapies. Many recent papers propose various algorithms for the clinical screening of patients with tinnitus. This example is by Langutz, a very well-known German searcher for tinnitus. The main points are case history, assessment of tinnitus severity, clinical examination, audiological examination, and of course, therapy proposal. Today's medicine can be divided in three main domains. The first one is conventional medicine, which is the usual approved one. The second one is complementary medicine, is already discussed. And the third one is alternative medicine, which is quite disputed today. What we try to do in our clinic in Lausanne is to join together all these three kinds of medicine and in the form of what we call today integrative medicine. Since 5 years, we conduct an observational and evaluative research in the clinics with all its questions and various possible answers. As you know, such kind of studies are of low level of evidence. Nevertheless, they are the first level of very new research. Thus, our way of doing has some limitation. The first clinical screening is organized in 6 steps. The first, anamnesis, case history. The second, clinical examination with otoscopy. The third, questionnaire about the handicap of tinnitus. The fourth, audiometry with different tests. The fifth, a specific tinnitus anamnesis. And at the end, a therapy continuum to find the best solution. This clinical screening is conducted to many possible ways and therapies sketched on this algorithm. The aim of my presentation is not to present all these ways, but to discuss with you each step, notably with its own main point and eventually controversies. It is really a teamwork with 5 goals. First, to try to find the condition leading to tinnitus, to exclude treatable ear or other pathologies, to appreciate the impact of tinnitus on daily life, to propose an adapted and personalized therapy, and to avoid, at the end, prescribing useless or harmful therapy. The first step, as said, is anamnesis. We focus on some main points. The first would be a clear ear anamnesis, and of course the description of the tinnitus, notably to see if it is continuous, pulsative, clicking, and other way. Then we look for the presence of other health problems. We list the drug used by the patients. We look for head and neck trauma, for acoustic trauma, dysfunction of temporomandibular joints, and cervical spine problems. Cervical spine problems and temporomandibular joint occlusion must be excluded, and they must be referred to specialists of this domain. The list of possible other health problems is very long. They can notably be cardiovascular, metabolic, hematological, neurological, and neuropsychological. The search for these different possibilities is orientated by the anamnesis. The first important point is to separate pulsatile tinnitus which represent less than 1% of the cases from continuous tinnitus. In this case, an auscultation of the ear area is done. One of the most common possibilities is a glomus jugular tumor, but we can also have other possibilities such as a arteriovenous fistula or a myoclonia. Second step is the clinical examination represented by otoscopy. Otoscopy does not only mean to see inside the ear, but also front side and back side. This seems to be evident, but it is not so much. Sometimes patients did not mention that they had the operation of the ear, and the discovery of a retroauricular scare will open new questions. As written by the otologist Christian de Guy, the good fortune of otology resides in the fact that in most cases, a diagnosis can be established through careful otoscopic examination. The tympanic membrane is the window to the middle ear. The aim of otoscopy is thus to separate what is normal from what is pathological. When it is pathological, it is necessary to find which pathology is present and if this pathology has a relation with tinnitus. The third step is the assessment of tinnitus handicap. This is done by specific questionnaire. In our clinic, we use the Tinnitus Handicap Inventory, the THE, abbreviated THE, with content 25 questions and a double visual analog scale. It highlights the severity of the handicap, which can be divided into 5 progressive grades: slight, mild, moderate, severe, and catastrophic. This questionnaire can be divided into 3 subscales: functional, emotional, and catastrophic. These subscales are very important, notably for the follow-up and to give a first orientation for the treatment. The fourth step is audiometric examination. The first audiometric examination counts at least 3 different tests. The first is the search for hearing level, of course, air and bone conduction. The second is the discomfort level. And the third is the search for tinnitus frequency by comparison. So it will give such kind of graphic representation that we will have for every patient with a tinnitus. As explained by the audiologist Roser, the most basic diagnostic audiological information comes from comparison of air condition to bone condition threshold. This means that it is mandatory to make this post-condition test. Otosclerosis is a very good example to represent this. Otoscopy is normal. Hearing loss is of transition type, resulting from the fixation of the stapes demonstrated by CT scan imaging. It is sometimes associated with tinnitus. The objective of audiometry is to separate normal and abnormal hearing level. If we find a hearing loss, we need to know first if it is symmetrical or asymmetrical. We need to try to find the type and the severity of hearing loss and to search for a known or unknown pathology. Acoustic neuroma is another example of the importance of a good audiometry. Otoscopy is normal. Hearing loss is of perception type, usually unilateral, resulting from a benign tumor of the auditory nerve that we can see on imaging MRI. It's usually associated with a unilateral tinnitus. Another important point of audiological examination is a search for hyperacusis. To do it, we use 2 tests: the Johnson Hyperacusis Dynamic Range Quotient, GHQ, and the CALFA Hyperacusis Questionnaire. And at the end, we have this result. You see the audiogram with this test and the questionnaire we use, of course, in French in our clinic. We complete this examination of tinnitus by the tinnitus matching. The idea is to separate tonal and atonal tinnitus. And we do that with an old app developed by Disyncra, not more used on the market, but other ones are existing now. And it's very interesting to have this approach. The fifth point is a tinnitus-specific anamnesis that we conduct not at the beginning of the consultation, but after the first 4 steps. In the literature, you will find many different lists of questions, and we have tried to summarize and to fix on some very specific points to be more clear, but of course this can change with the answer of the patient. What we are particularly looking for is a characteristic of tinnitus, the beginning, the duration, or the patient is describing the tinnitus and so on. We look for sequelae of head and neck trauma, for residual acoustic trauma, for adverse drug reaction, stress and emotional states, and of course, other related problems. The search for tinnitus as drug adverse reaction is very important. Today, we studied around 600 drugs with tinnitus and adverse drug reaction. This table represents the list of the main non-steroidal anti-inflammatory drugs, which are largely prescribed. 9 columns of results are visible on this screen. Each column corresponds to an official drug compendium from 6 countries: US, Canada, Germany, France, UK, and Switzerland. And 3 are related to a pharmaceutical compendium. The red colors means that tinnitus is a frequent adverse drug reaction between 1 to 10%. Such listing are the result of the research conducted in our tinnitus lab, which is always running. Another example is with antidepressant drugs. As you can see on this screen, the upper part of the table are the new antidepressant drug. And as you see, a lot, too much red, I will say. But it's a difficult topic because the relation between tinnitus, depression, and antidepressant is quite complicated. It's a kind of a vicious circle which can lead to some difficulties. Of course, as an otologist or as a tinnitus screener, we are unable to discuss the pertinence of the medication, but we need to discuss with the general practitioner and to see if these drugs are really necessary or not in some situation. So in other words, drug adverse reactions are very frequent, certainly usually underestimated, and we really need to take care about this situation in the consultation. I will discuss some controversial points to finish my presentation. They are hydration, electrosmog, and sleep. Why discuss these points? Because they have certainly a relation with tinnitus. The first is hydration. We know today that the body content of water is about 60%, but the brain needs 75% of water. This is quite high. The other organ with so much need is the heart. What is interesting now that there are more and more studies to demonstrate that the people with bad hydration, they have cognitive problem and other brain function. So when we know that tinnitus is produced by the brain, we need to maybe make a correlation between hydration and tinnitus. The second problem is electrosmog. It's also a very controversial point, but the psychologist Jose Sandoval wrote one day, remember that you are an electrical being. I will just give you an example. The hepatocellular carcinoma, in very new recent studies conducted by the firm Therabionics, have demonstrated that such kind of tumor, they produce low-level radiofrequency electromagnetic field. And if we give a phase opposition of the same low-level radiofrequency electromagnetic field, we block the growth of the tumor. Just to say that probably we are really electromagnetic. So we need maybe to have more care about this problematic. The third problem is sleep disorder. Sleep disorders are difficult to discuss, but the relation with tinnitus can have two directions. Or the tinnitus produce the sleep disorder, or the sleep disorder produce tinnitus. Once again, it is important to try to discuss this point. And finally, we have at the end of our algorithm, the therapy continuum. And as you have seen, we are 3 specialists in the clinic. So most of the time at the end, we discuss the 3 together and see in which direction and or which kind of first therapy we can propose. As I said before, we try to avoid to prescribe harmless or useless therapy. And I participate in 2 years before in a study we conduct at Stanford University about all these over-the-market drugs that you can buy for tinnitus. And we demonstrated that none of these kind of medication or remedies with better are not efficient. So this is the algorithm we do in our clinic. Seems to be complicated, but at the end, it really helps us a lot to do that. And maybe to conclude, one point is very important. I think that the first screening of a tinnitus patient is very important. We need to have a good structure, and maybe it plays, as some people say, a placebo effect, but even it is important to do it correctly. And just to conclude that the Society Aurelie with Sonova, they are developing a new application for tinnitus patients. The idea is that the patient will have some, they will be able to do a part of what I discussed now. And of course, in one moment, they need to have a good clinical first screening. Thank you very much for your attention.
Thank you, Albert, for your very practical insights into how to clinically manage tinnitus patients. We will now begin our Q&A session with our panelists and experts. We will be starting off our discussion based on the questions that you have submitted throughout the event today. If more questions arise during the discussion, please feel free to write them in the chat. We will react to them ASAP. Now allow me some time to connect with our expert panelists in the virtual discussion room. I'll see you there soon. So welcome now to our roundtable discussion with our experts tonight. First of all, again, a very warm thank you to all our experts for sharing their insights tonight with us and also for their willingness to participate in this roundtable discussions. Before we dive into the questions that I guess we will receive on the live chat in large numbers, I would like to make a general statement. One major takeaway from me from this symposium tonight also was that in the past, when I looked at and learned about tinnitus, oftentimes there was a statement saying, well, there is no cure for tinnitus anyway, get used to it, live with it, as messages to many patients. And there may not be a cure to heal tinnitus in some extent, but what I learned tonight was that there are a lot of great approaches to help patients who suffer from tinnitus to improve their quality of life significantly. And I hope you agree with me. So there is a lot of hope and a lot can be done for tinnitus patients. I hope you don't scream and completely disagree with me. But for me, this is a very important point to make, that there is hope for tinnitus patients and a lot can be done. Do I get a thumbs up or a complete disagreement from your end? So thank you for this agreement. I think we can start taking the first questions now. And one question that I would also immediately have is, when we think about tinnitus and talk about tinnitus, we very often talk about the tinnitus patient, and we put all tinnitus patients in one box. But I was wondering whether there are not approaches to at least somehow distinguish and differentiate tinnitus patients, and whether we already have approaches to kind of phenotype them and also potentially offer different solutions for different types of tinnitus patients. Maybe David, you want to take this question first?
My old friend Stefan, I think that's a really insightful question, because within the tinnitus population, there is huge heterogeneity, huge variety of experience, age, hearing loss, etiology, all of those things. And we need to do some work to try and get to grips with that. People are looking at that clinically, to look at whether there are themes within tinnitus experiences that need different approaches. But actually, some research groups are starting to use machine learning to really get to grips with those populations. In Nottingham, we've done that with the cochlear implant and tinnitus population, and used machine learning to look at complaints of tinnitus within that patient group, and we've just published that work. So I think in future, it may well be there are particular characteristics that we pick up. Now, what's most important, I think, and I'd be really interested to hear what Rilana says about this, is the patients who say, I'm not in very much trouble, but as a clinician, you instinctively think, actually, I think you are. And on their questionnaires, they don't necessarily max out the scores, but you just get that instinctive feeling that actually there's a big problem here. So maybe I don't want to usurp your chair, Stefan, but maybe I could just ask Rilana to comment on that patient group.
I'm happy to take questions among the group and pass on the questions for sure. I mean, also, Albert, feel free to weigh into this question. Rilana, do you want to comment?
Yes, thank you, David. That's a very interesting point you make there. I have the same sort of experience as you are telling us. What we have to consider here is that next to the experience of tinnitus, we also sometimes assume that a person has some sort of illness inside, right? And we as an expert oftentimes are able to pinpoint a little bit that in this person something might be off, whereas the person is not yet ready or is not yet able to come to terms with their experienced illness. So as we said before, tinnitus might be just a phenomenon, whereas it's not really associated with a disease. That doesn't mean that there's not an illness. And as with every illness, a person experiencing illness needs to come to terms with what the person is experiencing, first of all, and second, needs to gain insight into how the illness affects them. And I think we, as clinical experts as well, play an important role into helping them clear up these issues, if you know what I mean. I never go to a patient and say, I think you are fearful of the tinnitus, because those are very psychological words. We have to come to terms with the patient's words and terms and experiences and our insight into what might be happening. So that is my 2 cents.
Thank you. Rilana, any comment from your end, Albert, to the question that I asked?
As I said in my presentation, for me, one patient is one tinnitus. And we need to check every patient with their own story, own problem, and so on. I don't think we can really make great generalities. We need really to take time to talk with the patient and try to understand his own problem.
Okay, thank you. We are getting a number of questions from the live chat, and one of the first questions, maybe Albert Mudry, you want to pick this up, is what is your experience with tinnitus onset during COVID and or after SARS and COVID vaccination? Do you see any correlation?
It was a question we had already 1 year before at Stanford. And we tried to make around all the physicians were in contact with Stanford and outside if we find a relation between COVID-19 and tinnitus and vaccination and tinnitus. And until now, we receive very few reports to have a direct relation between both. One study published that it could be when somebody has tinnitus, some cases demonstrated that it was increased a little bit with the COVID, but the number has not enough high to really make a relation today. Maybe we will learn more in a few months, but today there is not really a relation here.
Okay. Thank you. Rilana, a question to you. Do you use cognitive restructuring previous to exposure? And if so, are there any specific cognitive distortions that must be addressed?
That's a very interesting question as well. If we look at science and we look at exposure studies, we actually see that too much cognitive restructuring before exposure actually diminishes the effect of exposure. Since we are working here with an experience-based learning alteration, we want the person to go through an experience as realistic as possible. What we aim to do is kind of retrain the brain into the perception of the tinnitus as well as all the emotional reactivity. If I beforehand try to soothe a lot of things, it might be that the exposure isn't that helpful. On the other hand, I think it's very important that the person knows before treatment what tinnitus is, what happens in the ear, in the brain. Also, the person should really know his hearing profile so that it is very clear from a medical standpoint what facts there are. So we have to convince the patient kind of that the person is not in grave danger. While you're doing the exposure therapy, you add your cognitive techniques and you add your sort of more explanatory framework within your therapy course. So I wouldn't explain too much beforehand because it's not possible anyway. As Dr. Mudry just told us, every patient is a person in itself, of course, and has its own mountains to climb. So what we want to do is keep that as individualized as possible and try to explain the individualized experience later on with our knowledge of theory, and maybe some cognitive restructuring, first of all, takes place by our behavioral methods, and then by us discussing some issues with the patient as well. So
basically education and
yes.
Diagnostics, individual diagnostics of the patients is an extremely important first step before you apply any therapy.
Yes.
Thank you. So the next question, what do you think about TRT, tinnitus retraining therapy for the management of tinnitus? It goes to the panelists, but do you want to go first, David?
Yes, thank you. I'm just amused by a typo in the.
Me too. I was also like. Okay.
Anyway, let's let can pass us by. Okay, so tinnitus retraining therapy was produced by Pavel Yastrebov, Jackie Sheldrake, and Jonathan Hazel in the early 1990s, and it was a fantastic recipe book for dealing with tinnitus for people who hadn't dealt with it before, and it helped so many clinicians and so many patients, and it was really, really helpful. It's been very difficult to test in randomized controlled trials, because how do you test something that's really quite structured and quite elaborate against the placebo? Well, Rilana and I did the study that we did together that looked at standard care and then advanced care. That's one way of doing it, but that's not really been done with tinnitus retraining therapy. I think the principles of it are fantastic. I think the people behind it are my great old friends and they're fantastic. But I think when I first went to university around this time of year in 1980, I needed a recipe book to teach me how to cook. It wasn't very long before I knew how to cook, and I didn't need the recipe book. And I wonder a bit if tinnitus retraining therapy is a recipe book, and actually for those of us who can learn how to do these things, we can become fluent and engaged with these things.
Thank you. We have more questions coming up here, and Albert, there is one question to you. Do you use magnetic resonance therapy in your clinic, and what experiences do you have with this type of therapy?
You mean outside magnetic therapy?
Yeah, I guess it's transcranial magnetic stimulation.
They are in Geneva. They've tried with few patients, but as I know, the first result were not very excellent. So, but I don't do it in my clinic. It's too complicated and too big.
Any other opinions on this approach, David, Rilana?
Yeah, thank you. So the data is a bit mixed. There have been some really good controlled trials, but it's very hard to do placebo-controlled trials on magnetic stimulation therapy because people know if they've had the therapy, and doing a sham version of it is quite difficult. Where there's been decent sham studies, my understanding is that the effect has been quite limited and not sustained. Mm-hmm. So I'm not sure, and Albert is nodding his head. I'm not convinced mm-hmm. that it's a way forward. I mean, this is the complexity with tinnitus. You know, where do you hit it? Do you hit it in the cochlea? Do you hit it in the auditory cortex? Or do you hit it in the associative cortices dealing with behavior and personality and those sorts of things? Maybe all of the above, maybe at different times in the tinnitus journey. I think this is one of the things that's actually really interesting about this phenomenon.
I would like to weigh in as well. I think these are very important and interesting experiments we are at present carrying out. All the sort of activity-based stimulations, I guess, are of interest. I think also that we have to spend some time in discussing what an effect is and how that is measured. So if we are trying to manipulate biological mechanisms or activity patterns, then it would be helpful if we would have an observation available where we could measure this activity. Unfortunately, it is always the case in these studies as well that the effects are measured on a questionnaire. So the question is here, what are we measuring? Are we measuring the sort of wishful thinking of the person, or has anything actually changed in the brain? So it's good to talk about this. What outcomes do we use for what intervention? If I am actively trying to change behavior, I would hopefully be able to observe behavioral change. If I'm trying actively to manipulate brain activity, it would be helpful if we were able to observe changes in brain activity. And that is, until now, I find it a little bit disappointing that in all the studies so far, this has not been done. And the effects might be very aspecific to the activity that has been used. So that is a little bit what I also wanted to bring to the table, that we have some work still ahead of us.
I think that's extremely well said, Rilana. And you know, our great hope and aspiration here is for a biomarker that will give us some kind of objective measure, whether that be biological or neurophysiological or brain activity. We need something that's objective rather than the tinnitus handicap inventory or the tinnitus functional inventory, both of which are fantastic, and we use them in Nottingham and I love them, but actually we need something that's more substantive than that. And you know, people around the world are really working on that.
Yeah.
So it's also a call to action for more research on the basic mechanisms and on outcome measures, how to assess, maybe also and quantify tinnitus and the improvements related to any tinnitus therapy. We have in the chat a couple of more interesting questions. Just now we have a question coming up, whether you have any experience on the use of FM or remote microphone systems in tinnitus patients or in hyperacusis patients, and also the application in general of hearing instruments with low gain to people who suffer from tinnitus. Any experience on your end from the clinic, or David or Albert or Rihanna?
Just something about hyperacusis. Hyperacusis is a major problem in patients with tinnitus. So we need first to be sure that they have an hyperacusis, and then first try to do something for the hyperacusis. And then we can discuss to treat the tinnitus, or at least to propose something to release a part of the tinnitus. But hyperacusis is so important to check out when you see a patient. And most of the time, it's not done. And then when you do a good anamnesis, and then we have also questionnaire, as I show you in the clinic. And it's very important because at this moment, we propose a kind of that the people relearn to listen to noise with a few months of education with hearing aids, and then we can go further on with the tinnitus.
Any other comment to this question, David or Rihanna?
Yeah, I think Dr. Mudry, that's really, really helpful. And my experiences with patients with sound tolerance disorders, and I think I'm happier now to use that term rather than hyperacusis or misophonia or diploacusis, or I think I'm happier to use the umbrella question, is that we have to be both really careful with the use of amplification devices and technology, but actually there's real opportunity here. So these patients are experiencing problems with their auditory sound environment, and it's possible that FM devices, localizing hearing aids and those sorts of devices might be really helpful. In the days when hearing aids just made everything louder, of course, that was disastrous for them. But actually now that we can work with different forms of loudness perception and really work with that with different algorithms, it may well be that there's some work that we can do both with hyperacusis, so people who find the outside world too loud, misophonia, people who found particular sounds too loud produced by human beings, diploacusis, people who find sounds differently in different ears. I think there's a huge area there. Now, how are we going to solve this? Clinicians on their own? Absolutely not. Clinicians and companies like Sonova? Potentially yes. And that's not to big up Sonova, but that's just to say, I know that Sonova are interested in working in this area. It's not going to make them a ton of money. It's a niche area and it's interesting, but it involves a lot of human misery. So that's the area where I'm really interested in engaging with.
I will add something. It's the reason why in our clinic we have an audio prosthetic, because in many times we need to have the help, and we can propose this solution because we have this in the clinic. But when you don't have this, it's much more complicated.
And as far as I'm concerned, from the more behavioral or psychological perspective, I think it would be interesting to see whether we could have equipment which helps me as a psychologist to help the patient expose themselves to more richer sound environments. What you want, of course, is to have the person being able to maneuver through normal daily life. So with decreased sound tolerance, this is often not possible. And I think that a smart device would help us create environments for the person in which they can train themselves to again, sort of in a pleasurable way, interact with sound, either from the environment or typical sounds they are decreased tolerant for. So yeah, now what we do is often we use sound bites or little sound fragments and then play it to the patient with the use of a computer or a telephone. However, when this would be more standardized, this would be more helpful, I guess, and also very interesting to research as well to see which sort of soundscape works best for whom, right? So you would be more able to customize per patient what would help them the most without masking too much, but to provide exposure opportunities, let's say. That's from my perspective what I would be interested in.
I think that's extremely interesting, Rilana. I think this idea that we could modulate soundscapes in order to give people gradated exposure might really be helpful in terms of these different sound tolerance issues. Yeah, I think that's really, really interesting.
So unfortunately, we are at the end of this session, and we closed the Q&A. Time flew by very quickly, so thank you for your participation. I heard a number of really interesting statements also at the end. Also the request for us as a manufacturer and provider of hearing care solutions to take actions in some fields where we haven't been active. And for us, it's a strategic drive at the moment to expand the scope of our offerings and our activities beyond the very classical hearing care and hearing systems. So it's well heard, and we certainly are active in these fields. So let me thank you for the questions and answers, and then maybe close the session. Thank you.
Bye-bye.
First, I would like to introduce another additional speaker that will be available in the online recordings as of tomorrow. Christian Hauptmann from the University of Munich, the Bio-Inspired Information Processing Department, and also CTO and Chief Science Officer of Aurelium, is offering a talk on non-invasive neuromodulation approaches to tinnitus management. Secondly, as has already been briefly mentioned by Albert Mudry, I would also like to briefly mention the tinnitus solution we as Sonova have been working on. Based on latest research findings, we developed a tinnitus management solution which fosters the collaboration between patients, HCPs, and ENTs along the entire tinnitus rehabilitation journey. It is self-paced for the patient, but guided and coached by the health professionals. The systems will be launched through the Sonova Audiological Care Networks beginning 2022. If you want to know more, please feel free to reach out to us via the contact details that you will be provided with the recordings at the end of this event later on. And finally, we have a QR code which leads you to a feedback page where you can share your feedback about this event and also find access to contact details and also to the recordings to us. So with that, I would like to say goodbye, good night, and thanks everybody for participating and joining us tonight. Thank you.
Welcome to my talk entitled Non-invasive neuromodulation for tinnitus. In the next 15 minutes, I will introduce to our clinical research project on a novel non-invasive treatment option for patients suffering from subjective tonal tinnitus. Several neurological diseases show high pathologic synchrony as one part of their pathology. Parkinson's disease, epilepsy, migraine, depression, or tinnitus are examples for diseases where high synchrony positively correlates with the intensity of symptoms. Our neuromodulation concept targets this synchrony. Our concept combines principles from neuromodulation and neuroplasticity with the goal to induce both acute and long-lasting symptom improvement. On the next slide, I will explain how this works in detail using this diagram with many colored dots. Each of these dots represent neurons connected with each other. The three groups of neurons represent the same neural network in different states. Same color indicates that the neurons are synchronized. So on the left side, all neurons are gray. So all are synchronized. This state is the pathologic situation. Cause symptoms like tremor in Parkinson's disease and the tinnitus sound. Now we apply short stimulation where each stimulation pulse affects a subpopulation of the whole network, indicated by the colored circles. The pulses are not delivered all at the same time, but in a sequence following each other. The result of this stimulation is illustrated in the middle diagram. The neurons within each subpopulation show the same activity and are synchronized. But there is no synchrony between the subpopulations, indicated by the different colors. We call this a multi-cluster state. When this multi-cluster state is reached, we can stand back and make a short pause of 1 to 2 seconds in our stimulation protocol. We utilize the strong pathologic connections, which force the neurons of the whole network to finally go back to the synchronized state. But before reaching the synchronized state, on the left again, the network goes through a period where all neurons show different states or phases. This desynchronized state on the right side is important for us, since while the network is in this state, it starts to unlearn its pathologic connections, allowing to build up the long-lasting benefits. We call this stimulation pattern coordinate reset stimulation, abbreviated by the two letters CR. All this is easy if you have an electrode placed into the brain, as we do for the treatment of Parkinson's disease by using deep brain stimulation. But to treat tinnitus, we tried to obtain similar results by using non-invasive and more patient-friendly methods. From MEG and EEG studies published in the last 15 years, for example, by Nathan Weiss, now working at the University of Salzburg, we know that enhanced pathologic delta and reduced alpha activity is observed in tinnitus patients in the primary auditory cortex. This is the activity that we need to modulate to induce benefits for the patient. The primary auditory cortex is directly connected to our hearing system, and our hearing system shows to have a tonotopic organization, which we utilize. Short tones of different frequencies induce activation in different areas of the primary auditory cortex, as you can see on the left side of this diagram. By playing sequences of such short tones, where the tones need to be centered around the most prominent spot of pathologic activity, representing the dominant tinnitus frequency, we can realize a stimulation pattern, which is very similar to the coordinate reset pattern introduced on the last slide. So who could benefit from acoustic CR neuromodulation and how it is applied? This is the topic of the next slide. Since the concept requires a clear spot of synchronized activity, as observed in subjects having a tinnitus sound with dominant frequency, also called tonal tinnitus, this new treatment is designed for this patient group with tonal tinnitus. While all participants in our clinical trials showed chronic tinnitus, we believe that acoustic CR neuromodulation might also be effective in acute tinnitus. But this has to be shown in clinical trials first. As you all know, most patients with chronic tinnitus suffer from this disease since a long time. Since it cannot be assumed that a treatment can change activity that is burned into the brain since 20 years, for example, it is easy to understand that also acoustic CR neuromodulation needs time to work. In our studies, we learned that 4 hours per day of listening to the stimulation sound for several weeks is required to induce the long-lasting benefits. In the course of the treatment, the therapy tones need to be readjusted several times. The stimulation signal is typically applied through earphones at a level just above threshold, so the patient can play the stimulation during his or her daily activities. Our clinical data, which I will show in detail in the next minutes, show therapeutically significant improvements in approximately 75% of treated patients. We start with a study done at Jülich Research Center before 2012. 63 patients with chronic tonal tinnitus were treated with different types of CR neuromodulations for 12 weeks. We observed that tinnitus severity measured by the tinnitus questionnaire was reduced after 12 weeks of treatment, which is shown in the diagram on the left side. For example, we started with only 5 subjects with mild tinnitus. After 12 weeks of therapy, we had 14 subjects indicating that the tinnitus is of mild nature. From our scientific perspective, it might be even more important that we were able to show that the pathologic activity, which was measured in periods without active stimulation, reverted back to normal, which you can see in the middle diagram and on the right side. The pathologic delta activity, indicated by the white bar, was significantly reduced after 12-week treatment. And alpha activity, indicated by the gray bar, which is typically reduced in tinnitus patients, was increased and closer to the normal state. So observed improvements were stable during a 4 weeks treatment break. Therefore, we call these effects long-lasting effects. In the next study, we tested if this treatment can be applied in a normal practice setting by ENT doctors. For this, 200 patients were treated by 23 ENTs over a period of 12 months. The short version of the Tinnitus Beeinträchtigungsfragebogen, TBF-12, was used to assess the amount of tinnitus burden. After 12 months of therapy, we observed a reduction of TBF-12 of 38%, and at the end of the trial, more than 50% of participants indicated that the tinnitus is no burden to their life anymore. Similar results were obtained by the audiologist Mark Williams from the Tinnitus Clinic in London. Here, the THQ was used as primary outcome measure together with a visual analog scale. In total, 66 patients were treated. All measurements showed a significant improvement after 24 weeks of treatment with acoustic CR neuromodulation. As you all know, many patients with tinnitus have hearing loss. Actually, hearing loss might be an important cause of tinnitus. Therefore, we did a clinical case study where one patient suffering from both hearing loss and tinnitus was treated through his hearing aid. In this patient, we observed a pretty strong reduction of tinnitus handicap inventory score from initially 40 points to 12 points after 3 months of treatment. Also, the VAS scores improved by approximately 30%. 2018, together with the ENT Dr. Hannes Wurzer from Munich, we tested a modification of our acoustic CR stimulation protocol. Hearing loss in a certain frequency range requires higher intensity to perceive the signal within this frequency range. Such more intense sounds actually recruit more neurons within the hearing pathway. Also, our stimulation signal needs to be more intense to be just above hearing threshold in patients with strong hearing deficits. Following our scientific concept, we would need to increase the spread of the 4 stimulation tones in patients with strong hearing problems to still address with each of the tones one distinct subpopulation of the affected primary auditory cortex, as shown in the left diagram. Our study showed that 72% of the treated patients with the hearing loss benefited from therapy with a mean reduction on the score of the Tinnitus Fragebogen by 27.4%. This new hearing threshold adapted CR neuromodulation seems to be quite suitable for patients with hearing. Our last clinical trial to assess the effects of this novel therapy is about to be published very soon and was done at the Veterans Administration in Portland, US. Because of blast trauma, the Veterans Administration has very strong expertise in treating patients with tinnitus and is doing outstanding research in this field. In this trial, we compared the effects of acoustic CR neuromodulation with the effects of cognitive behavioral therapy, which is seen as the gold standard for tinnitus therapy in the US. 61 patients were included and treated for 24 weeks. The tinnitus questionnaire was the primary outcome measure. This is actually the first time results are presented. The primary endpoint of the study was met. We observed a TQ score decrease post-baseline by 8.3 to 15 points in both groups. The TQ reduction in the CR neuromodulation group was slightly more pronounced as in the CBT group. The relative TQ reduction of up to 33% is very similar to the effects observed in previous trials. The results of this US trial showed that our novel sound-based therapy is just as effective or more so than CBT, which brings us to our future plans. Cognitive behavioral therapy and acoustic CR neuromodulation address completely different mechanisms within the brain to reduce the burden of tinnitus. Both therapies are very important and show good results. The experts from the Veterans Administration agree that a combination of CBT and acoustic CR might have the chances for even better effects. So realizing tools to allow the parallel application of CBT and acoustic CR is a logical next step in our future plan. To reach as many patients as possible, and then recent clinical trials showed that CBT cannot only be applied through group therapy, but also by internet-based therapy. The combined application of CBT and acoustic CR within an app and supported by healthcare professionals seems to be a good target for future plans. To summarize, our novel therapy, acoustic CR neuromodulation, combines the principles of neuromodulation and neuroplasticity to induce long-lasting benefits for the patient. The new therapy was developed using computational neuroscience, and several studies showed consistent improvements in the range of 30 to 40% reduction in questionnaire scores. The working principle was proven by EEG recordings in the first clinical trial. The combination of CBT and acoustic CR seems to be the next logical step to address the very common psychiatric comorbidities of tinnitus as well. Finally, I would like to thank all my colleagues from Jülich Research Center and my colleagues from the involved startup companies for their strong support to realize this clinical research program. Thank you for your attention.